Hello, everyone, and thank you for joining today's webinar on improving the Diagnostic Odyssey for rare disease patients. I'm Sarah Dash, President and CEO of the Alliance for Health Policy. For those who are not familiar with the Alliance, welcome. We are a nonpartisan resource for the policy community dedicated to advancing knowledge and understanding of health policy issues. And today we will be delving into a topic that is often forgotten in health policy conversations, and that is the topic of rare disease. And specifically, we'll be looking at the journey from illness to diagnosis of rare disease. And the name Odyssey, I think we'll see in this webinar why it's called a Diagnostic Odyssey. So the Alliance gratefully acknowledges the support of Alexion Pharmaceuticals for supporting today's webinar. And we have some really fantastic speakers today who are going to help us understand this topic better. Let me go over some quick housekeeping items. First, you can join today's conversation on Twitter using the hashtag AllHealthLive and join our community at All Health Policy, as well as on Facebook and LinkedIn. Please get your questions ready and prepare to be active participants. You can use the speech bubble icon in your webinar dashboard to go ahead and submit questions at any time throughout the broadcast. Please feel free to send them anytime. We'll get to as many of them as we can. And if you have any tech issues, of course, feel free to send those in too. We'll do our best to help you. Lastly, a recording of today's webinar, including our slide decks, will be made available on our website soon after the webinar. So here with me today to speak about rare diseases and how we can improve the Diagnostic Odyssey, the time from symptom onset to a final diagnosis, is a truly esteemed group of experts. First, we're so pleased to be joined by Dr. Matthew Might, who serves as the director of the Hugh Cowell Precision Medicine Institute at the University of Alabama, Birmingham. At UAB, Dr. Might's research focuses on precision prevention, diagnosis, and therapeutics across rare disease, cancer, and common or chronic conditions. Dr. Might's journey from computer science to medicine was inspired by his son Bertrand. In 2012, Bertrand became the first patient in the world to be diagnosed with NGL-Y1 deficiency, and Dr. Might has a remarkable story that he will be sharing with us today. Next, I'm pleased to introduce Dr. Stephen Kingsmore, who is President and CEO of the Rady Children's Institute for Genomic Medicine. Previously, Dr. Kingsmore served as the D. Lyons Missouri Endowed Chair in Genomic Medicine at the University of Missouri Kansas City, School of Medicine, and Director of the Center of Pediatric Genomic Medicine at Children's Mercy Hospital in Kansas City. We're delighted to also be joined by Linda Goeller Blount, President and CEO of the Black Women's Health Imperative. Previously, Linda served as Vice President for the United Way of Greater Atlanta, where she led the effort to eliminate inequalities in health, income, education, and housing through place and population-based work. Linda also serves on the steering committee for the Rare Disease Diversity Coalition, organized by the Black Women's Health Imperative. Thrilled to have you here. And last but certainly not least, I'm pleased to introduce Nellie Gannison, a principal at Avalier Health, where she advises clients on the implications of quality-related healthcare policies, including, but not limited to, public and private quality reporting programs, value-based care, and payment and delivery models. Prior to joining Avalier, Nellie spent 6 years at the Institute for Healthcare Improvement, focused on population health and hospital-based quality improvement. So with those introductions, we're going to launch today's conversation by hearing from Dr. Matt Might, who is going to share his perspective on why this topic is so important, the challenges that patients and caregivers face throughout their diagnostic journey, and his own experience. Matt, thank you so much for joining us today.
Well, thank you so much, Sarah, for having me. And I have far more than even I could sit and if I had a full hour, I couldn't tell you everything there is to know about what it's like to be on the caregiver side when it comes to diagnostic odysseys. So I'll try to give you a sense of why this is so important and what this is like for me, and maybe even sort of start forward and jump backwards in time. So today, I run this research institute at UAB focused on finding therapies for folks with ultra-rare genetic diseases and other diseases too, but that's really sort of the bulk of what we do. And the reason I do this at all is because, 13 years ago, I had a child that launched onto a diagnostic odyssey and pushed me from a path and, being a professor of computer science into ultimately academic medicine. And the first part of that was what we call the Diagnostic Odyssey. So when my son Bertrand was born, we had no clue what was wrong. It was clear something was very wrong, but we had no clue what was actually wrong. We didn't know why he had seizures. We didn't know why he had developmental delay. We didn't know why he had a movement disorder. We didn't know why, for some reason, he couldn't cry tears. It was just incredibly perplexing. And what happens in that state, when you don't know what your child has, is you start bouncing around between we call it hot potatoing. You move from specialist to specialist, never quite getting the right answer, just always being told, well, I don't really deal with this. This isn't, or from one organ system to another, like, well, we know the liver's involved, but you need to go talk to the folks in neurology because it's the brain. When he was born, technologies to bring a swift end to a diagnostic odyssey didn't even exist. So you couldn't just go get an exome sequence or a genome sequence and look at the entirety of the human genome in one fell swoop and say, oh, this looks like it might be the problem. We had to wait for that technology to come. And the good news is it actually did. So I think by the time he was 2 years old, this is around 2009, a team of geneticists we've been working with at Duke University reached out and said, hey, there's this new technology. I know you've been waiting for genome sequencing, but we think there's a better way to do this through exome sequencing, where you can just look at the small fraction of the human genome that actually counts, or we think mostly counts when it comes to genetic disease. And it's faster and it's cheaper, and we can cover it as part of this new research study to see if this will actually work in people. And so we did that, and it actually worked. So looking at the 2% of Bertrand's genome that actually encoded proteins, they discovered that he had in fact inherited 2 mutations, one from me, one from his mom, and a gene called NGLY1. And when they looked at these mutations, said this quite clearly wipes out the function of this gene. So this makes it very suspicious for as potential cause for all the problems. They said there's just one issue here. No one's ever seen a disease caused by this gene before. There is no disease associated with this gene. We don't know if this is really it. So we've got a little more homework to do. They said that if this is what it is, then Bertrand is the very first patient in the entire world. And back then, that kind of a finding was sort of remarkable and novel, to think that you could find a brand new disease. And what technologies like exome and genome sequencing have done is they've made this actually a rather regular occurrence. I'm in touch with several parents around the world now where their child was the first one for their particular disease. There has been an explosion in disease discovery as a result of these technologies. But back then it was still a novel thing. And so I said, well, what do we do? How do you even move forward? And prior to that point, I remember it was all about figuring out how to get medical records between hospitals, because there was a sort of unified EHR where you could actually easily export your records from one place to another. I remember even building my own medical records system by hand. So I'm an electronic medical record system that I could port between physicians and send them passwords and links for them to log in. And now suddenly it was a whole different ballgame. There was no specialist to go see anymore. No one knew what this thing really was. We knew what it was, but no one really had any expertise in it. And I realized right away that we had to develop a community. So I turned to social media and again, did sort of a first instance of what has now become very commonplace. I created a blog post that was designed to go viral and essentially find the other patients that didn't know what they had with this disease. And the crazy thing is that it actually worked, and the community did form around this brand new disease. And that pushed me further on this path in life, where I started focusing on first building community, then doing the science, and then actually delving into daring to look for treatments for this devastating disease. Unfortunately, Bertrand passed away in October, just shy of 13, but not before many treatments had been discovered. I think he was on 3 experimental treatments by the end of his life that significantly extended the length, but most importantly, the quality of his life, something that the other patients can now benefit from as well. And I go back now and I think about at the very beginning when we were told that he had a life expectancy of at most 3 years, and he made it to 13 thanks to significant advances in diagnostics and then similar advances on the therapeutic side. And I feel lucky now that my day job is to do the science that will bring these advances both on the diagnostic and the therapeutic side to more patients. every single day. But I'll never forget how it began and the 4 years that it took to finally get to an answer. And in some sense, the strangeness that this isn't more commonplace. We've known how to do this for a very long time, how to sequence genomes and exomes and in some sense jump straight to the answer for these patients. And yet for some reason, this has not yet become an everyday practice whenever we suspect there to be a genetic disease. With that, I'm happy to yield my time to the other panelists.
Thank you so much, Matt. And I think on behalf of all of us, we can really express our condolences and so sorry for Bertrand's loss and for everything that you went through. Really appreciate your being with us. And I am curious, you know, so much of what you said is there's threads between your own professional expertise that helped to move things along, the newly developing technologies, you know, over the past 13 years. And I'm just curious if you could, like, perhaps just what do you think has been the most promising advance from your perspective that you've seen in terms of either technology or diagnosis or speed to diagnosis that might help other families dealing with similar issues?
Yes, it's a great question. I do think that exome sequencing really created a huge shift in the landscape for getting an answer for so many of these families. You know, the success rate, you know, even in these clinics where you're looking at the most intractable diagnostic odysseys, it's around 35 to 40%, and it's ticking up over time as we get better and better. So you sort of know right out of the gate that you've got a decent chance at bringing it into many diagnostic odysseys with just those technologies. Genome sequencing is a little bit better. It'd be better if we were better at understanding the rest of the human genome, but science is still advancing there. But in terms of bang for buck, exome sequencing is a tremendous game changer and has been for quite a while now, and bringing answers very quickly to families that desperately need them.
Great, and I know we'll get into this, and maybe Stephen Kingsmore will help tee this up for us as well. But for those who are totally new to this topic, exome sequencing, is that something you can only get at certain academic medical centers? Like, where do people even begin to even know that that's an option or something that they could or should look for if they're having these mysterious symptoms?
Yeah, so I wish it were sort of the first thing we went to anytime there's a suspected genetic disorder. Unfortunately, what actually happens really depends on where you are, what your health provider is, what your payer, who your payer is, and what their policies are. It's not standard practice right now to reimburse exomes or genomes when it comes to suspected genetic diseases. In fact, paradoxically, even they may do many rounds of genetic panels where they look at a handful of genes instead of all of them, trying to guess what the answer might be. And I still haven't figured out why we do that, because that can be very expensive actually to keep guessing. But it is very patchwork. It really depends where you are. Here in the state of Alabama, we're lucky that we have a state-funded initiative, so that for many of the patients that we think need it, we can do it on sort of a research basis. There are certainly clinical providers for it as well, but again, reimbursement is inconsistent across the board when it comes to actually getting it. And it's not cheap either. It's not super expensive, but it can be a few $1,000s to get these sorts of things done.
Well, thank you so much for that additional context, and again for sharing your own journey. And so next, for the additional clinical context, we'll turn to Dr. Stephen Kingsmore. Stephen, welcome.
Thank you very much. Great to be here. I am Stephen Kingsmore. I'm the president and CEO of Rady Children's Institute for Genomic Medicine, which is part of Rady Children's Hospital in San Diego. So let me go from Matt's personal story to kind of framing this issue for you. So first of all, we now know that there are more than 6,000 genetic diseases. That's a staggering number. It's one of the triumphs of modern medicine. That number changes every day. Just as Matt told you with his son, this number changes every day. It goes up every day. And so each morning we have to refresh our database because there's a new disease to deal with. What we've discovered, which was completely unheard of even 10 years ago, is that these diseases are massively underdiagnosed. And in fact, they underpin many of the most common presentations of disease. So seizure disorder, Matt talked about this, epileptic seizures. There are over 1,200 genetic diseases that can cause a child or an adult to have a seizure. We used to call intellectual disability mental retardation. Thankfully, we've retired that term. But would you believe it, that this is not some kind of environmental thing? There are 1,700 genetic diseases which we already know trigger intellectual disability. And you can see the other statistics there. Now, each of these diseases is located in a place in the human genome. The genome is the code of life, the DNA code. We're now very familiar with this because of COVID. We understand about variants. Variants are changes in the genetic code. And with COVID, they cause the disease to take a turn and be different, maybe to have different symptoms, such as our current Delta variant. In the human genome, they trigger disease, that they code for essential functions, and when we have variants in the human genome, they cause genetic disease. Now, the beautiful thing about genome sequencing is it allows us in one test to examine all 6,000 genetic diseases at once. So one test for them all. One ring rules them all. One test solves them all. When Matt experienced his son's illness, what I'm showing you was not possible. He was one of the first to get the benefits of this type of technology. Well, here's the curve which shows what's happened since then to the price of decoding the human genome and to the speed of decoding the human genome. And that's why it's a completely wrong concept to use the word Diagnostic Odyssey. It's a wrong concept to think that a doctor shouldn't be able to tell a parent within a day what's wrong with their child. We can now decode the entire human genome and explore that across 6,000 diseases in 13.5 hours. It costs, on a research basis, $700. That's less than a brain imaging study. Next slide. Okay, I want to show you the evidence that underpins Matt's experience. So this was funded by the National Institutes of Health, and it was one of the first randomized controlled trials to examine whether or not genome sequencing saves lives. So on the left, we have 213 babies who are critically ill, just like Matt's son. They're in an intensive care unit. We gave them genome sequencing. Now, back then, it took a little bit longer. It took 2 or 3 days to get to a positive result. As Matt said, between 20% and 50% get a diagnosis in 2 days. Now, look at what's downstream of that. 93% of those babies had clinical benefits. It changed their treatment regimen. 39% had a better outcome, just like Matt said. But let's look at parents. We sometimes forget that we're treating families, not individuals. Mums and dads, 100% of the time, said this is great. Thank you. Now let's look at the negative tests. This is a big shocker. A genome not only saves lives when it's positive, it also can do it when it's negative. 72% of the time, doctors said a negative genome sequencing test was beneficial. Why is that? That's because we're ruling out diseases. That's because the doctors can go look for something else, maybe an infection that's causing this child's symptoms. Look what parents said. 96% of them said, hey, having a negative genome test is great news. My baby has a healthy genome. Next slide. So that was one study, but now around the world, in multiple centers, in multiple healthcare settings, in multiple payors and systems, we've shown this again and again and again over the last decade. There are now, as you can see, 23 published studies, and they all tell us the same thing, which is that genome sequencing saves lives. Next slide. As Matt said, we have a policy problem. We have a serious policy problem. This technology was invented in the United States. Would you believe it today? It's national policy to do this in children all over the United Kingdom. That's England, Wales, Northern Ireland, where I'm from, Scotland. It's also national policy in Australia. We invented this, but we have a legislative problem. We haven't been able to have this be adopted. Now, in response to this, our center now offers this to children all over North America. And there are 70 children's hospitals who send us samples every morning. Right now, there are genome sequences being done at our institute from 70 hospitals across North America. One of those is really important. One of those studies is really important. It's called Project Baby Bear. The California legislature said, prove it. We believe it, but prove it. Show us that this works in California. Next slide. What we did really stunned them. We put genome sequencing into 5 very different ethnic, racial, and socioeconomic regions of California, all the way from our bread and butter place where we grow crops to the most urban areas of California. Next slide. We enrolled 184 Medicaid babies to receive this, and 2 of them are shown there. They both benefited from this, and this saved both of their lives. But what we found, which really shocked the legislators, was this saves money. By decoding a baby's genome, doing it as fast as you can possibly do it, you're able to decrease the cost of care, as is shown in that picture. Next slide. In fact, we save $20,000 for every child we sequence. Sorry, I don't have any more slides. So what am I asking you? I'm asking you to do what's being done right now in Michigan and in California. The governor of California just signed a law July 1st saying for Medicaid babies, this is now policy for California. In Michigan, September 1st, there will be a policy which says this is normative for Michigan Medicaid babies. This is covered nationally by private insurance, by Anthem, Blue Cross Blue Shield. If you have their plan, you get this. The real problem is disparity. Right now, Medicaid are the folks who are dependent on the government-funded health system don't have access to this in the other 50 states. We need to fix that disparity. Thank you.
Thank you so much, Dr. Kingsmore. Stephen, it's great to get this additional context from you. And if I could ask you to bring your camera back up, because I neglected earlier on to say that Stephen Kingsmore can only be with us through 12:30. Thank you for taking some time out of your day. I'm so glad you brought up this point about health disparities, and really as an equity issue. And given that Medicaid covers, on average around 50 or more % of the births in this country, and in general, states have a lot of discretion about what to cover and what not to cover. That's really interesting. I'm curious if you could say more about this. So how does this work? Is this voluntary for parents on Medicaid to ask for their child to have a sequencing test, or is it, like, hey, this is one of the tests we're going to do in the hospital when your baby's born, just like we do any number of other kind of newborn screening tests or diagnostics?
So in those 70 hospitals, the moment you enter an intensive care unit, this is available, right? Cincinnati Children's, Tufts Floating Medical Center in Boston, Rady Children's Hospital in Southern California, Miami Children's Hospital, Nicholas Children's Hospital, Miami, all over North America. If you're fortunate enough to be in those systems, you can get a genome sequence with a single click on the electronic health record. If you're not, you can't. You can't. If you're born in a community hospital, you can't get this. And then there's the issue of who's going to pay for it. in all of those hospital systems outside of what's going to happen in California and going to happen in Michigan and outside of Anthem Blue Cross Blue Shield, you're going to get the bill. You're going to receive a letter after your baby's discharged to say, please pay for the genome sequence. We need to fix this, okay? It can't just be those who are wealthy who can benefit from this technology. This is invented right here in America. We need to end this disparity. Why is it that children in England get this routinely and we don't even offer it to our own babies? Why is it that the babies who are Hispanic, Latino, and African American can't get this technology? It's people of my skin color who are wealthy. It's CEOs' children. We need to fix this. We need to do it urgently. This saves children's lives. We estimate that this will save over 10,000 children's lives per year just in the Medicaid system. Let's fix this.
Well, thank you so much for joining us, Dr. Kingsmore. It's been a pleasure to have you, and we look forward to certainly further conversations. Now, thank you so much. And so now I'm so pleased to introduce Linda Goeller-Blunt. Linda, welcome to the panel.
Thank you.
Oh, hello. Awesome. Thanks for joining us, and take it away.
Okay, well, thank you, Sarah. And you couldn't actually have teed this up any better with Dr. Kingsmore's presentation and Dr. Might. You know, again, I want to add my condolences as well, and thank you for your service. So Dr. Kingsmore really kind of teed this up. He talked about the Diagnostic Odyssey not needing to take so long, and yet it does. I lead the Black Women's Health Imperative, and we're the only national nonprofit organization actually focused on advancing health equity and social justice for Black women and their families. And as you all are aware, this what should not be an odyssey does exist. Rare disease patients face significant barriers in diagnosis, care, treatment. Typically, it can take 5 to 7 years to get from symptom to diagnosis. For patients of color, it's more like 7 to 10 years. And patients of color face unique barriers that many others don't. I'm thinking about a recent patient who told this story of trying to get his kidney disease diagnosed and how long it took because his doctors kept insisting that he stop using illicit drugs or stop eating, fried chicken. They didn't perform the tests that he needed to get performed to actually diagnose his kidney disease. And often patients of color are not asked to participate in clinical trials where we could learn more. And that is the #1 reason why we don't see more patients of color in clinical research, is because their providers simply don't ask them. They make assumptions about what they will and will not do and don't ask. And when we think about advocacy, I know we're going to hear from an advocate. Advocacy is actually an issue of luxury. You have to have the income, you've got to have the time to get out and advocate, to be part of support groups, to go to the Hill, go to your state capital if necessary. And if you're low income, if you're working 2 or 3 jobs, you simply don't have the time to be an advocate. But sometimes that gets misconstrued as lack of interest. So to try to help focus on this issue and come up with solutions, the Black Women's Health Imperative, in coalition with a number of groups, launched the Rare Disease Diversity Coalition, out of a recognition that the barriers that I've talked about and so many more are pronounced and widespread among patients of color and low-income patients due to systemic racism, lack of access to healthcare, health insurance, as you've heard about, lack of people in color in research, and the lack of funding of research specific to populations of color. And those are just a few of the challenges. This coalition has over 200 people in it. And when you think about direct and indirect support, we're talking about something that's nearly $20 million in the making. This Rare Disease Diversity Coalition is really the first of its kind, and it aims to address the extraordinary challenges that are faced by people of color and people who do not have high incomes, as that we've heard about, who are living with rare disease, as well as their caregivers and families. So we brought together experts, researchers, patients, advocates, industry leaders, and policymakers to identify and advocate for evidence-based solutions and to alleviate the disproportionate burden of rare diseases on communities of color. And honestly, this conversation couldn't be more timely. The COVID-19 pandemic, coupled with the recently renewed focus on racial injustice in this country, has highlighted the urgency of these challenges and underscored the pressing need for action in the rare disease community. So prior to forming the RDDC, I had spent a number of years trying to get pharmaceutical companies into the conversation about increasing participation among patients of color in clinical research, and just never got anywhere because the pharmaceutical companies, as I heard, were said to me directly, they said, well, we don't want to have to talk about Henrietta Lacks. We don't want to have to talk about Tuskegee or J. Marion Sims. We're afraid to have that conversation. That's what makes the RDDC so important, is that these folks are fearless. And so this focus is to reduce racial disparities and income disparities in the rare disease community, to shorten that diagnostic journey from symptoms to effective therapeutics and treatment, to identify and advocate for evidence-based solutions, as I mentioned, and help to achieve greater equality within the rare disease community. Last February, the RDDC launched its action plan, which lays out concrete action steps to be taken by the RDDC members and others, and in our goal to address these challenges and to lay out a roadmap for what can be done to achieve equity. It provides guiding principles to address the kinds of issues that we're talking about today. So if you go to rarediseasediversity.org, please download the action plan and see what we are doing. This coalition receives its strategic direction from a steering committee and 5 working groups that are focused on provider education and engagement, patients and caregivers, government regulation and policy, delays in diagnosis and treatment, and research and clinical trials. And I actually co-chair with Dr. Marshall Summer, the clinical trials work group. And what we plan to do over the next 2 years is make observable and measurable improvement. And in addition to the steering committee, there's also an industry alliance that will, among other things, focus on diversity, equity, inclusion, and its relationship to better patient outcomes and research outcomes. We're using a variety of media platforms to engage with patients and caregivers, to provide a platform for them to amplify their voice and tell their stories, to share with the world. And we will have a number of social media and in-person kinds of events so people can understand just how important this issue is and see their own place in the solutions we're talking about. We hope that the RDDC will really set the example of effective partnerships, how to address medical bias and racism without fear, and how we can make progress toward achieving health equity. So thank you, and I look forward to the conversation.
Thank you so much, Linda. You've really laid these issues out so well, and really, even the example you gave of the gentleman with the kidney disorder, such poignant and hard example of how racism and bias shows up in medicine sometimes, right? And so applaud you for all of your work that you're doing. Wanted to ask you a follow-up question before we move to Nellie's presentation around diversity in clinical trials. And I'm wondering, particularly with the increased focus attention on racial inequities in healthcare over the past year, have you seen any change in terms of the recognition of the need for greater diversity in clinical trials? What concrete steps are you seeing that are either being taken or maybe are on the verge of being taken that give you some promise here?
So it's a little early, but what I can say is that it's on the radar screen. Last year, I can't tell you how many times people said to me, oh, racism, I had no idea, or health disparities, oh my goodness, I had no idea, or they're connected, we didn't know. So now folks know, and now people are beginning to think about this issue very differently. And what's encouraging is we've actually had research going back 30 years that looks at the connection between racism and gender discrimination and poor health outcomes. So now that research is being brought back to the forefront, and I'm hearing a very different conversation. The RDDC, is sort of out front of this, but people are really beginning to understand how important diversity is, not only among participants, but among researchers. Because what we know about evidence is what becomes evidence depends on who's asking the questions, who they're asking, and who's funding it. So once we've now broadened the scope and realized how important this is, I expect to see much more momentum and to see some real difference in the coming months and years.
Thank you. Thank you so much. And I have to ask you one other question, since you are the Black Women's Health Imperative, and Dr. Kingsmore talked about newborns and newborn screening, and there's been so much attention, of course, on the terrible issue of maternal mortality, and particularly the disparities there. And so from the standpoint of mothers and new moms, like, is that and rare disease, is your focus relatively more around children and newborns, or kind of like through the lifespan? I'm just curious kind of if there's a particular focus there.
Well, our focus is the lifespan. I mean, from the newborn girl up to, hopefully the 105-year-old who dies the good death. But to your point, part of what we are doing is helping moms understand what they can expect, what kinds of questions to ask, what to look for, and recognize when they're not getting the kind of care that they really should be getting, to protect their unborn, and protect their newborn, and protect them and their newborns in that first year postpartum. So this is really, you've seen what's been in the news. It's really important for us to make sure that we know what kind of care we should get and recognize it when we're not getting it.
Absolutely. Thank you so much.
Thank you.
Thank you. And now I'm pleased to be joined by Nellie Gennison from Avalier to tie together a number of policy threads that we've heard today. Nellie, take it away.
Yeah. Thanks so much, Sarah. Thank you also to the Alliance team for this very important discussion. I think, Dr. Might's comments are sort of that story and his own sort of life journey and navigating this, not only from a clinical perspective, but from a patient perspective, is why this conversation is so important and needs to continue. So I, will go to say that the three folks we've heard from sort of validated everything that we also discussed when we met. So I'm going to share a little bit about sort of I'm going to call it a paper, and hopefully like a call to action that sort of addresses some of the issues that were already discussed today. We at Avalier Health, I think Sarah introduced sort of the organization at the start of the call, had an opportunity to sit down in a roundtable discussion with sort of 15 to 20 folks in this space. So individuals that come from rare disease. We had Dr. Kingsmore there. We had a number of other clinical representatives, folks that came from the technology space. So, the Diagnostic Odyssey has sort of this foundation, or this groundwork, and what are the technological solutions to help this diagnosis be more efficient and more accurate. So we had folks from the technology space there. We had folks that sort of fund these different mechanisms that are in the space. To talk a little bit about what some of, not just, I think, the challenges that we heard today, but potentially what some of the opportunities are as it relates to scale and spread of these types of technology solutions. Everything that we heard today, I think, is not new for people that have been very close to this space, but I think for some of you that may be less familiar, it'll apply to some of the other work that you may be doing in healthcare. And if we go to the next slide, we sort of started this conversation by saying, okay, in an ideal world, what would ideal diagnosis look like? So, if you think of maybe even something as simple as diabetes, where it's a patient comes in, you can check their A1C, you can sort of predict what, what type of disease they have, you can predict what type of treatment they have, you can have some sort of variation of diet and exercise that can be applied to a patient, and then there's an appropriate diagnosis, right? The patient goes home, they sort of take care of the needs that they have as it relates to that disease. And not to say that it's easy, clearly, folks with sort of, very mainstream conditions, there's obviously still always challenges as it relates to things like reimbursement and as it relates to follow-up care and caregiver care. I think the difference is here is that each one of these steps within rare disease is, at least from what we heard from this discussion, is not consistent. the sort of misdiagnosis, kind of lack of information just in the clinical space and sort of the literature around what, what symptoms are that present for a specific disease and sort of symptom identification, what options are available for that patient. And then also, right, treatment. What are the different sort of treatments that are out there, and is there a treatment for a specific rare disease? So this idea of kind of what does good look like in the space has yet to be defined. And I think that that's probably like a very baseline piece that when we see what this journey looks like, there's clearly going to be a number of different challenges. But if we look at them sort of at a distinct perspective, maybe there are some options that can be identified to address each of those challenges. If we go to the next slide, the challenges that we discussed within that group, and I think that they're what we've heard on today's call in so many different ways. And I think, again, if you hear Dr. Might's story of somebody who had access to the system and who had great clinical knowledge of how to diagnose his son's care, there were still so many challenges. So if you look at folks that are in a rural area that face health disparities, as Linda mentioned, you're going to have sort of exacerbation of issues. But some of the challenges that we discussed as a group, and I don't think that these should be a surprise to anyone on the phone, but there's a high demand of what these patients need, especially when we think about sort of complex or chronic conditions that some of these patients may have already had. Misdiagnosis within this patient population oftentimes also leads to fear. If you think of yourself and sort of coming home with like a mosquito bite and you drastically search on WebMD for some kind of response. I mean, if you think of that, it's sort of to the 10th degree, there aren't necessarily, answers that we can find on the internet for a lot of what these patients are feeling or what these patients need or what the caregivers and the families need. Clinical education. This is a big one. And I think that this is some of what we talked about is the idea or the concept of rare disease is still new. I think the training is limited in medical school, and many clinicians don't see a high volume of these patients, so their experience in mitigating some of these issues is also very limited. Data maturity and regulatory barriers. Dr. Kingsmore talked a little bit about this around, the regulatory barriers to implementing almost coverage for genomic sequencing is very limited. Interoperability as patients see various clinicians. Dr. Might mentioned his own personal electronic health record that he carried around. So that idea of, a family going from a physician in one state to another state, but the having to have the same conversation about sort of some of the challenges that they've faced is definitely a barrier to sort of successful or optimal care here. Adoption and workforce. This sort of links also a little bit to clinician education. I think, many of the folks on the phone today would agree that the geneticists, the number of geneticists in this space are limited. There are, I think, tend to be less folks that are going into that world now, but that's definitely where more skill set is needed. The other thing too, just of the clinicians that are seeing these patients, patients and families are scared. They don't necessarily know what to do. I think empathy is very pivotal and key to these conversations, even if it's just sort of helping patients navigate who and where they need to see somebody. Finally, Linda talked a lot about equity. I would sort of link this, link equity here in this case also to the fact that, and I think Dr. Kingsmore mentioned this too, is, this type of treatment, this type of management of care is very evident and very present in non-rural communities, so urban communities, if folks are lucky enough to live in those spaces to have this access. But if you go out to sort of in Mississippi somewhere, you're likely less to have access to some of this genomic sequencing, and likely also less to have clinicians that sort of understand and have seen a higher volume of these patients. And then finally, sustainability. And I think this was sort of the crux of the discussion that we had is, there's a lot of energy around this now, and I think that there will continue to be, but, outside of funding, what are the mechanisms that need to be considered to sustain better diagnosis of this patient population, especially from a scale perspective. And then finally, we sort of presented these different challenges and barriers. And then I think the second part of this discussion really sort of focused in on, are there optimal solutions, and how can the discussion really start to continue? And I think we heard a lot of this in today's panel as well, specifically that, one of the big kind of takeaways from this is these are very, some of these are unique to, some of the challenges and barriers are unique to rare disease. Some of this is fixing it in kind of the larger healthcare space, right? So when we think about sort of regulatory barriers and interoperability and payment and coverage and reimbursement and access to care in rural populations, that is important to rare disease. It's also important to a lot of other diseases. So elevating that conversation so that recognizing and fixing the healthcare system will also, be opportunistic to help these patients, help rare disease patients, and be applicable to the Diagnostic Odyssey. I think, the integration of additional tools for patients to be able to use. I think that the point that Dr. Might made about building community in this space is incredibly important, something that we heard again and again in our discussion. And then finally, this idea of applying a global approach for rare disease, as Dr. Kingsmore said, this is happening all over the world, and it's not, and it could and should be happening here, but what are the sort of steps that are needed to make that happen? I mean, a lot of it is coming sort of from Medicaid and Medicare coverage, but are there other pieces internally around payers building consensus on what should be covered that would help this as well? For more information on this paper, you can actually find it on the Outlier Health website. It is a nice summation of sort of the discussion that we had today, and also where there's an opportunity to move forward as it relates to policy discussions and future research. So hopefully that sort of was a good way to end today's discussion.
That's great, Nellie. Thank you so much, and I'll ask you to stay on. You made such a good point. It's I've heard it say, like, if we could make the healthcare system work for cancer patients, we could kind of make it work for everyone. And it seems like this is one where if we could make the healthcare system work for patients with rare disease, or who are about to find out they have a rare disease, we could really, streamline it for everyone. With so many of these underlying issues that you called out. So let me ask, while Nellie and I are chatting, for our other panelists to come and join us here. And Nellie, I'm just wondering, that was kind of an editorial observation, but but I'm curious if you have thoughts on that as you really pulled all of this research together.
Yeah, I think, we've seen this in some other disease areas. One of the things that did come up in the discussion, and I think folks on the phone would probably agree, is, policy is one lever to allowing to I guess moving the needle forward of how diagnosis can be covered, what the interoperability piece looks like. An idea of sort of bringing, one of the things that came up in our discussion was this idea of bringing sort of this consortium of payers to discuss kind of the shared benefits of genomic sequencing and these viable solutions to addressing the problem, whether that might be a shared pool of genetic data. So Dr. Kingsmore talked a little bit about that, right? They did that in sort of the state of California around the question of prove it, and to show that there is value and that Medicaid should be covering this. And oftentimes these are sort of, the issue becomes very local, but if there was a way to elevate that to sort of the national landscape as they've done in other countries, I think that would show the viability for it to be happening in different states. So even in communities where the rural access is a disparity, those patients would have the ability to travel somewhere where they could get that care. I mean, we've seen that, we see that in various spaces in oncology. So I think that could work here.
Yeah, thank you. That's a great point. And we're getting some audience questions. This is the moment where we're like, so many questions, so little time. We have about 10 minutes. So I want us to have a great lunchtime discussion here. And, want to ask each of you, are there sort of 1 to 2 policies that you think could make a real practical difference in the next 1 to 3 years in terms of improving this Diagnostic Odyssey? And maybe, Linda, I'd love to start with you and just ask each of you if you have thoughts on what would be like top of mind for you in terms of policy change.
There are. I mean, obviously, Dr. Kingsmore mentioned Medicaid. There's that saying, if you've seen one Medicaid program, you've seen one Medicaid program. I mean, we really need to make sure we have insurance coverage. There's some hope around sort of the next phase of the 21st Century's Cures Act to make sure that we look at health literacy and clinical trials diversity and of obviously patients and providers. And, you know, FDA has some requirements around diversity in clinical trials. It wouldn't be interesting if those requirements were actually enforced and we could make sure that we saw diversity in clinical trials participation. And as we look at drug therapy and how we value them, I think we should include the lived experiences of patients of color in that evaluation and valuation process that ICER goes through, because what may be of value to one population group may not be to another group, but that doesn't mean that the drug is not valuable to that patient group. So I think we've got a great opportunity to look at how we're evaluating therapeutics, evaluating how they're paid for, and how we communicate about the availability of genetic testing, because again, that, you know, is not universal as we know. And so that's what I'm hopeful about it over the next few months, that we will actually see more people and hear more people talk about that need, so that more people begin to ask those questions. And to to Stephen's point, you know, why is this journey so long? He's right, the diagnostic journey should not be that long.
Thank you. Yes, clearly an area where the policy and practice hasn't caught up to the science, or you know, certainly the realities of people's lives. Matt, what do you think? And you know, I'm curious if you have any thoughts on the data or interoperability front, but certainly anything, any thoughts from your end on key practical policy changes?
Sure. You know, I'm going to echo agreement with the need for reimbursement. I mean, it's if it's not covered, people aren't going to get it, and it shows up. And actually, I also want to just touch on the disparities issues too. It, you know, the fact that it's not reimbursed has a dramatic impact on disparity space. And anybody who's a part of the rare disease community will tell you that the underrepresentation is very visible. I mean, when you look at the composition of patient groups, and what's striking about rare genetic disease in particular is that we can measure very precisely just what the degree of underrepresentation is. You know, for example, if you take recessive genetic disease, for every group, you can predict exactly how many patients there should be. And then you can measure how many there actually have been diagnosed. And so you can be very quantitative about the degree of underrepresentation. But even using your eyes at you know, patient gatherings, you can see it. And so I think you could view, you know, rare disease as a way to measure the impact of policies in general designed to address disparities, because you'll see the impact dramatically and immediately and very quantitatively. And then when it comes to interoperability, I'm very excited about the potential of, you know, recent rulemaking with ONC regarding things like FHIR, this interoperability standard for exchanging medical records. I think it's early days. We don't know quite yet if this is going to be exactly what we've been hoping for the whole time, but it's certainly a big step in the right direction. And I hope further efforts to ensure that there's seamless access to your electronic medical records continue.
Thank you. So you don't think we should just teach parents how to create passwords for each of their doctors, and that's like you were able to do?
That's what a lot of parents still do today.
Yeah.
No, we shouldn't have to do.
Yes, exactly. Not to be facetious about it. It's terrible that that's kind of where we are. And I'm glad you brought up the, you know, again, on the disparities point and sort of measuring that difference. And I think we'd certainly be interested to see more resources and be able to share those with our audience too. But again, I think when people talk about structural inequalities or, you know, structural racism, even in healthcare, it's such a, again, a good example of, if you're not looking for it or you're not covering it in populations that have been disadvantaged or populations of color, like, then you're not getting the information, and then that's not feeding into the research or the treatments, right? So Linda, I'm seeing you nod. I don't want to editorialize too much here and speak too much out of school, but I thought I wanted to call that out as also as an example.
Yeah, I couldn't agree more.
Thank you. So let me ask, there's another question from the audience, and I want to leave a little bit of time for just some final thoughts from everybody on the panel. But I think this is an important one. Someone from the audience said, all the challenges that you note, all the collective you note, are all too real for many. This is a board member of an organization dedicated to a specific rare disease, in this case pericarditis, asks, how best can we align with other similar organizations to share information, conduct outreach, to help individuals who are newly diagnosed or in the process of seeking a diagnosis, and make sure that the process is a little more streamlined for them. Linda, you're nodding a little bit. Let me ask if you have a thought there as far as what they could do.
I would say, please reach out to us and join the Rare Disease Diversity Coalition. I mean, we hope to assemble best practices, information. This isn't a situation where we're telling everybody to do the same thing. There are a number of different rare diseases represented in this coalition. What we're trying to do is raise awareness of how to shorten this journey for everyone. I mean, obviously we're focused on reducing and eliminating inequalities and inequities, but everybody can benefit from understanding how to go about this diagnostic journey, and how to go about finding information, how to have a conversation with your providers, how to know what kind of research is even available, how to participate in a clinical trial. So sometimes just having a place where you can share information is really valuable, and that's what we hope to do with the RDDC, is to become that repository of practices, information, resources, so people can shorten that journey and try to do it with less fear. Yeah, because as Matt knows, I mean, that's every parent's fear, but he jumped in and he did everything he could, and it would be great if all other parents could do what you did, Matt, and have the kind of access to resources that you had and knowledge to do what you did. So, yeah.
Yeah, thank you. And so in the few minutes that we have left, I want to I'm curious, Nellie, like as you participated in this roundtable where you pulled together, payers and practitioners and patients and kind of folks from across the spectrum. Just can you speak to like what are if any kind of the coordination challenges or the what more could be done to make sure that people are speaking with each other around how to improve the Diagnostic Odyssey?
Yeah, and Linda, I applaud sort of your efforts as well, because I think something, and again, I am probably of everyone on the panel, probably the most like least knowledgeable about rare disease, like more broadly. But what I would say in comparison to other disease areas in terms of who we were talking to, like there's a priority amongst the folks that spend a lot of their time doing this, but there is a lack of priority from sort of individuals that are maybe coming down from like a higher policy level, right? So when we think of things like the number of diagnosis codes that are available for rare disease, it's so limited. And so the priorities like coming down from almost the top down, in my opinion, seem very limited. So coordinated efforts, I think, are definitely necessary. And I would say at this point in time, there's a need to just raise visibility of like what some of these barriers are. And I think there's lots of these organizations that are doing that. And once that sort of visibility is lifted, there's an ability to coordinate a little bit more across key organizations. I think there are a lot of groups that are focused on this, right? So I think of the individual that you received the question from, there's a lot of independent sort of patient advocacy community groups, community forums focused on individual types of rare diseases. But there isn't necessarily like, I mean, there are a number of different organizations focused on rare disease, but bringing together sort of all of those challenges. So Sarah, I don't think I answered your question, but what I would say is sort of the ongoing efforts to continue to address this, right? The more people that are doing this, the better, versus the less people that are out there sort of building community and kind of fighting for some of these challenges.
Yeah, thank you. And I want to be mindful of time, but Nellie, I know I didn't really give you a chance to answer the policy question. Do you think there are one or two areas that really folks can agree on, and not only kind of across different sectors, but maybe even in a bipartisan way, if I dare say?
Yeah, I mean, I think and this gets very wonky, but the coding, right? The need for more code so that clinicians can actually like appropriately diagnose. Not to say that there is an appropriate diagnosis, but we can at least get closer to the data, right? The more codes that you have, you can get closer to sort of what those diagnoses look like. Dr. Kingsmore talked about how every day he refreshes and there are more rare diseases, but the codes haven't increased, right? The number of sort of diagnosis codes haven't increased. So to me, like that, if I that seems like a very large lever and one that is feasible, since there are codes being created for all kinds of weird things now these days. So I think that is one. I think the second is this idea of sort of data sharing, which Dr. Might also talked about. Is it's not just sort of the clinicians that need the data. I think now the patients are very interested in the data. So providing that type of access, widely around, like, what does the data look like for my disease that I've been diagnosed with? Have 10 people been diagnosed with it, or have 100 people been diagnosed with it, or am I N of one? I think that those questions are important too.
Great, thank you. Well, I want to end on a thank you, and you all have provided such an amazing context. In one or two words, let me ask each of you just what gives you hope for improvements over the next few years. And Matt, if I may start with you, is there anything in all of these conversations that gives you hope that the situation will improve?
Well, I'm certainly optimistic that the situation will improve, and I hope that we take the Diagnostic Odyssey as the starting point for the Therapeutic Odyssey more generally from now on, and not that you get a diagnosis and it's over, but that we encourage folks to continue pushing and develop similar kinds of technologies on the therapeutic side so that we get not only answers, but treatments.
Thank you. Nellie, what do you think?
Yeah, I mean, I have to say, stories like Dr. Might's, I think, is also to me where there is motivation to continue to do this, right? So there is a need within the community, and it's not just, the patient stories, I think, are motivation for me. So elevating, again, I'll go back to my earlier comment of just elevating some of those stories so that it's a priority at the policy, at the higher up of the policy angle is important.
Thank you. And Linda, you get the last word.
Well, thank you. I think the fact that we're having this conversation, this is what gives me hope, because before last year, there were very different kinds of conversations. There was resistance. Now there's much more acceptance to looking at the social and historical context that we live in and what that means for rare disease, for diagnosis, for therapeutics, for cures. So I encourage everyone on this call to keep yourself abreast of what's going on, dig in, and hopefully share the belief that we all have, which is these inequalities just don't have to exist. Thank you.
Absolutely. Thank you. Thank you so much for joining us today. Linda, Nellie, and Matt, you all have really enlightened me, I think, and all of us on this call. Thank you so much for joining us, and we look forward to future conversations. For those interested in more information, check out allhealthpolicy.org, and there you can also find, I believe, contact information for our speakers and for the resources that they shared today. Thank you again to Alexion for supporting today's webinar. And finally, for those who are looking at perhaps the fundamentals of health policy and you're interested in learning more, check out the Alliance for Health Policy Handbook. It includes chapters on coverage, on how the FDA works, and on a number of other health policy topics that you might find of interest. So please check us out and fill out the survey. We do take quality very seriously, so we want to hear your thoughts. Once again, thank you very, very much for joining us today for this conversation on the Diagnostic Odyssey for rare disease patients, and have a wonderful afternoon.
Thank you.
Thank you.